Thank you everyone for joining. I am John Strickler from Duke University Medical Center, where I am a GI medical oncologist, and it's a pleasure that you're all here today. I know a number of you have submitted questions for this webinar, and I want to thank you for submitting those questions. I will try to answer many of those questions in a first 10-minute overview of this topic of molecular residual disease testing. And if you feel like I have not answered your questions, there will be an opportunity to go back and answer a few more after I give my quick 10-minute overview. And then we'll have also some opportunities for Q&A. So thank you all for joining today. First, what I'd like to do is just give a quick overview from my perspective as a GI medical oncologist about the use of circulating tumor DNA to detect molecular residual disease. And probably the best way I could introduce this topic is to explain where we are in the year 2022 and how we got here. So for many years, we have followed national guidelines for survivorship for patients with stage 1 through 3 colon cancer. And those guidelines have been pretty stable over the past 25 years. Specifically, they have focused on using some basic tools to perform surveillance for after resection with curative intent. So the basic components are regular physical exams, CEA, imaging, and colonoscopy at pretty regular intervals. The challenge with that, however, is that a lot of what we've been doing for the past 25 years is not necessarily rooted in the evidence that this improves outcomes for patients. It's really based on kind of established norms and practices that have been going back for decades. And that's particularly problematic for certain things like CEA, which torments many of you as patients and family members, and also medical oncologists like myself. CEA, just for a quick overview, is a blood-based biomarker that we use to detect whether cancer is still present or not. And in fact, what we've found when we've kicked the tires on that biomarker is that it is very insensitive, very poor at detecting cancer when it's normal. And also, there are a tremendous number of false positives. And in fact, up to a level of 10.0, there are more false positives than true positives. And this is a real big problem, because whenever we see an abnormal value, we want to understand, why is that value abnormal? What happened? Where is that cancer? So we do a lot of scans, imaging, et cetera, and many times we're doing so off of a false positive. That's stressful for patients and families, and certainly not a great way to give care. So it's in that context of a very flawed survivorship model that, you know, we've taken a step back and said, okay, what other technology can we bring to bear to be a lot smarter about how we do surveillance for patients with stage 1 through 3 colorectal cancer? And one of the new technologies that has entered into the clinic in the last 10 years is this so-called liquid biopsy. Now, there are many potential applications for liquid biopsy. And when I say liquid biopsy, this is based on this idea that if there's cancer present in the body, that cancer can shed little tiny fragments of DNA into the bloodstream, and those fragments can be detected with a routine blood draw. And as I said, there are many applications for this liquid biopsy. One of them is to detect what we call molecular residual disease, or just minimal disease when there's nothing else visible on a CT scan. Now, it has taken decades for us to master this technology, and the reason is because when you talk about detecting a fragment of tumor DNA in the bloodstream, you're really talking about detecting one tiny abnormal fragment out of an ocean of normal, non-cancer related fragments of DNA. And it's taken many years to develop that technology. One of the ways that we can identify that fragment of DNA is through this so-called tumor-informed approach. A tumor-informed approach means that when the cancer is removed from the body for a person with colorectal cancer, You then sequence the tumor to look for unique signatures of DNA that are only in that tumor and not in the person themselves, not something they were born with. And then from that profiling of the tumor, you can create a custom panel of 16 mutations that are only found in that cancer. Now, the cancer was physically removed from the body with the surgery, so there should be no more fragments of those DNA left. But if you detect that DNA, then that's obviously a very concerning sign that there's still cancer present, just not readily detectable through our traditional imaging technologies. So that's the background on the liquid biopsy and how we do molecular residual disease detection. I think the question that all of us have is, how does this test perform in the clinic? Specifically, how does it perform for people who have stage 1 through 3 colorectal cancer treated with curative intent, which means treated with surgery? And so far, the data has been very promising. It appears that when you compare CEA, our more traditional approach, against circulating tumor DNA, the circulating tumor DNA is both more sensitive and more specific. So more true positives, fewer false positives, and more true negatives, fewer false negatives. In terms of what we can draw from this information, there are various times where a blood draw can be obtained after surgery. The first time point is usually around 1 month after surgery has been completed. And we found that with the tumor-informed assay, the so-called Signatera assay, a positive result off that one blood draw predicts about an 80% chance of the cancer coming back. Now, I think one of the reasons why it's not 100% is that many of these patients go on to receive chemotherapy, adjuvant chemotherapy, and are subsequently have that DNA cleared. On the flip side, if the circulating tumor DNA is negative at that first postoperative time point, the chance that the cancer will ultimately come back goes all the way down to about 13%. What's particularly promising is that over 3 years, if you have serial negatives, the chance that the cancer comes back is 3% or less. So overall, very favorable if you have those serial negatives. So that's what we know about the data. Now, there is some updates to the Signatera data that came from Japan recently. This is the so-called Circulate Japan data. I don't know if any of you have been reading about this. It has made quite a splash in our world of GI medical oncology. As a quick overview, that was a large observational cohort where they took about 1,000 patients with stage 1 through 4 disease treated with curative intent with surgery. And then they ran that Signatera assay, collected blood 1 month after surgery, then every 3 months thereafter. And what they found is pretty impressive. So specifically at that first postoperative time point, a negative result at that one time point had a 95% 12-month disease-free survival rate. A positive at that one time point was 55% disease-free survival. So it really did separate people in terms of their risk of the cancer returning. In terms of what the sensitivity was just for that one time point, about 65 to 70% of all recurrences were detected at that single postoperative time point. So it looks like it was a very powerful tool. Another fascinating finding from the Galaxy data was to look at the impact of chemotherapy, which is routine for patients with high-risk stage 2 and stage 3 colon cancer. They found in patients who had no evidence of disease and circulating tumor DNA negative at that one postoperative time point, that there was no difference in disease-free survival, either at 6 months or 12 months with giving chemotherapy, which suggests, needs to be proven in a larger study, but it suggests that if a person has no detectable circulating tumor DNA at that time point, that we may not need to even treat them with chemotherapy at all. And that would be a wonderful thing for all of our patients to be able to avoid treatment with adjuvant chemotherapy, because some of the side effects can be devastating. hopefully not in anyone who's been on the line here, but there can be some serious side effects of chemotherapy. And if we can avoid those side effects, that would be the best case scenario. And then finally, the Circulate Japan data also looked at patients who were positive at that first postoperative time point. As I mentioned, that's a very high-risk feature. And what they found is that the use of adjuvant chemotherapy substantially improved the disease-free survival for patients with stage 2, 3, and 4 disease who had circulating tumor DNA at that first postoperative time point. And in fact, it also was substantially associated with clearance of that circulating tumor DNA. So it suggests that there may be a role for intensifying treatment with adjuvant chemotherapy in those patients who unfortunately have a positive circulating tumor DNA at that one time point. So all of this data is early. I think we do need to see some validation in a larger trial, but it suggests that this could be a tool we use for all of our patients with stage 1 through 3 disease in the future. We're not there yet, but I suspect 5 years from now, this will be a practice-changing technology, though it still needs to be validated. There are trials ongoing in the United States and still in Japan, and I, for one, am very excited by seeing those results to see if these early, very promising signs from Japan are confirmed, and I do think that would change our practice if those results are confirmed. And with that, I want to highlight a couple questions that came in from the group. It's always a little dangerous to screen share on these Zoom calls, but I will try my best to do that. So let's go ahead and start. So starting with this question, how can I, a patient with metastatic colorectal cancer, benefit from information from circulating tumor DNA as opposed to the traditional CEA and CT scans? What I would say is we are not yet ready to forego CEA and CT scans in favor of circulating tumor DNA. I think that this will be an adjunct or an addition to CEA and CT scans, that we can use all of this data to help us find the right path for our patients. I would say that we can use it in addition, and some of the data from Japan, if it's confirmed, would suggest that we can be more intensive in our approach if there's a positive circulating tumor DNA, and maybe spare people the side effects of treatment if there's a no detectable circulating tumor DNA. But I would point out that no test is perfect. Circulating tumor DNA as well is not a perfect test, so we just can't we can't just turn everything over to circulating tumor DNA. We need to use all of our technology available to us. Another question that came in that I'll focus on here is, what's the latest news regarding immunotherapy treatment for colorectal cancer? Can it be monitored with circulating tumor DNA? And I think this is a great question because it points out that while I've been talking a lot about survivorship and people with stage 1 through 3 colon cancer, you can use this same technology for people with metastatic disease, and you can use it to monitor response to immune therapy. For those people with what we call MSI high colorectal cancer, that is treatable with immune therapy, and you can monitor changes in circulating tumor DNA with the tumor-informed assay, and also with other assays as well. And those changes, if they're favorable, do correspond to better prognosis and better outcomes with immune therapy. So yes, you could use it for this purpose. And last question that I'll focus on here today is, how accurate are circulating tumor DNA and cell-free DNA? Would you still need a colonoscopy? This is a great question. The test that we've got here is optimized for people who have an established diagnosis of colorectal cancer of various stages. In terms of its accuracy, it would never replace a colonoscopy. I would not put all my eggs in one basket and skip a colonoscopy in favor of this. I'm not sure if a solitary colon cancer found on colonoscopy would be detected in circulating tumor DNA, but our data suggests that it would be the majority of the time. But I would not skip a colonoscopy in favor of circulating tumor DNA. So with that, I will kind of take some questions. We'll start with Dr. Weaver is feeding me questions here through the chat. So what is the correct protocol to follow after receipt of a positive test? Great question. And I think this is when you hear that some doctors are hesitant to accept this technology in the clinic routinely, this is probably the #1 concern on the part of my colleagues, fellow medical oncologists. Specifically, what am I supposed to do after a positive result? It's terrifying as a patient. And also the doctors feel that stress. And it's never good to order a test if you don't know what you're going to do with the result. I would say this: if you are planning to pursue this type of test, before the blood is collected, before the test is sent, I would encourage you as a patient to have a discussion with the doctor about, okay, this is what we're going to do if it's positive, and this is what we're going to do if it's negative. When I've had these discussions with physicians, I've encouraged the physicians to sit down and talk about this with the patient, with their patients as well, that this is a very powerful test. It tells us a lot about prognosis, but we need to have a plan. So what I would say is the correct protocol depends on the circumstances. There have been times where I've ordered it due to a high CEA, but nothing found on imaging. And in that case, a negative circulating tumor DNA would tell us that we don't need to do a lot of extra imaging and a lot of PET scans. A positive circulating tumor DNA suggests that we need to do scans more frequently. We need to think about PET scans, additional types of imaging to figure out where it's coming from. So I really love this next question that's coming in from Dr. Weaver. I have stage 2 cancer. Can Signatera help me avoid chemotherapy? I think that this is probably the sweet spot for this technology. I will try to summarize the challenge of stage 2 colon cancer as well as I can. Stage 2 colon cancer, fortunately, has a very good prognosis. It is considered typically curable with surgery alone. And there has never been a large randomized clinical trial that has shown a survival benefit for taking up to 6 months of adjuvant chemotherapy. That said, there are certain types of patients with stage 2 disease that have a high risk of the cancer coming back, on a par with patients who have stage 3 disease. And there are certain risk factors associated with that, specifically what we call T4 disease. So a large invasive stage 2 cancer that has not spread to the lymph nodes is considered high risk. And then there are some other high risk features. Until now, it has been considered routine to offer people with stage 2 disease who have high risk features adjuvant chemotherapy for between 3 to 6 months. At the same time, adjuvant chemotherapy, while in most people tolerable and safe, can have serious side effects. And we are basically told by our national guidelines to only give people with the highest risk features adjuvant chemotherapy. The data, observational data out of Japan would suggest that about 2/3 of recurrences are detected by that single postoperative time point. And that means it's missing about 1/3. So it's not a surefire bet. However, the data out of Japan has indicated that there's no benefit at all in giving someone with no detectable circulating tumor DNA adjuvant chemotherapy. So if you are on the fence about chemotherapy and can't decide if you want to do it or not, and you're right on the fence in terms of your risk factor, this could be a tipping factor towards observation. However, if your cancer has high risk features, then just know this certainly having a negative result could be helpful, but it doesn't totally put you in the clear. As of today, we don't have a definitive way to answer this question yet, but I would expect that within the next 3 years, which is not fast enough for you, but within the next 3 years, we will have the trial data in to know whether people with stage 2 disease can use the Signatera test to avoid chemotherapy. I'd love to have a conversation with this person because it's a very complex topic. The challenge that I've run into in my clinic is that sometimes you don't get the result back fast enough to make a decision. We like to start adjuvant chemotherapy within about 2 months of surgery, and sometimes that Signatera test is just a little bit too slow to come back to guide that decision. Okay, this next question I also really enjoy. Can the test be run if I had surgery a while ago? The answer is absolutely yes. And one of the most common problems we have in our clinics, and I'm sure many of you in the audience can attest to this, is that you could be 3 years out from your surgery, things are looking great on your scans, and then there's this CEA number that pops up high. And it's really scary because what does this mean? Is the cancer there? We just can't see it. So it is not uncommon for us to order a Signatera on a 3-year-old cancer specimen to make sure that the CEA is a false positive. And it's been very helpful in those scenarios for me in my clinic, so that we don't keep, we don't overscan and do a lot of excess imaging. So yes, we can absolutely run that years after the surgery. And next question is, would you recommend the test for stage 1 rectal cancer in addition to scans? So great question here as well. I would say this, currently the standard of care for stage 1 rectal cancer is assuming that it was stage 1 at the original diagnosis. So I'm speaking in that scenario, not a more advanced cancer that was downstage to stage 1. But if the cancer presented as stage 1 and was successfully resected, I have not typically ordered Signatera or MRD in this scenario because the prognosis is so favorable. And I think we need to go back to the question of, what are we going to do with a negative result? What are we going to do with a positive? I think overall the prognosis, fortunately for stage 1, is outstanding. And I'm not sure what we do with a positive result in that scenario. But if, I would have a conversation with my patient with stage 1 disease. And if that person says, you know what, I don't know what I would do with a positive result, but I have to know, and then we would order it. So, but I've not typically used it in a stage 1 setting. I typically use it where we're unsure what we might do. Great. So want to thank everyone for joining tonight. And, it's been a pleasure to have this patient webinar. I think this is a really exciting technology. We've got whenever you have technology, sometimes the technology moves a little bit quicker than the doctors and the medical community. And we are trying our best to learn about this technology, its strengths, its weaknesses as quickly as possible. And my vision is that this will be part of our care probably in a few years. But I think it's an exciting time, and I hope that it improves our outcomes for our patients, giving the right treatment to the right person at the right time. So thank you all for joining us tonight.